Good morning from Miami Beach. It's Dr. John Bennett broadcasting for Neurosurgical TV. Today we have the pleasure of having Ashish Tandon, MD and neurosurgeon from India. He's going to give a lecture on the concept surgical spectrum and POTS spine. Welcome, Ashish. It's all yours.
Thank you. Thank you so much, John, and good evening from Jabalpur, India once again. It's a pleasure to be with you once again. What I have tried today is to bring the basic concepts here, but how management of POTS spine has changed, what we all should be aware of about the disease, and our way of looking at the comprehensive management of POTS spine. It's a very common disease, and all of us should be well prepared to treat with the best of current evidence that we have for the disease. So with this brief introduction, I'll jump in directly to the topic. We know that pulmonary tuberculosis is very common, and there are endemic areas around the world. However, we are more concerned about extrapulmonary tuberculosis, which constitutes just about 3 to 4% of all the cases of tuberculosis. However, even this number is huge because 10% of the extrapulmonary tuberculosis would be skeletal tuberculosis, and more than half of which would be involving the spine. So spine is the most common area or the organ that is the site for extrapulmonary tuberculosis. And in spine, the most common is thoracic area, specifically the thoracolumbar junction, lumbar, and then finally you have the cervical spine. And it's in that order. Now, as we know that the spinal tuberculosis, the mycobacterium involves the spine always secondarily. So there is a hematogenous spread of these dormant bacilli to the spine. And most commonly, the area involved is paradistal. And the reason for that is it's sort of superior and inferior end plates. So the superior end plate of the lower vertebra and the inferior end plate of the superior vertebra. And the reason is that the vessel, the artery supplying is basically gets divided into two and then supplies the end vertebral area, specifically the anterior superior margin or the anterior inferior margin. So that is where the foci of the lesion most commonly is. However, we do have pure central body disease or the posterior involvement, or then there are other forms like tubercular arachnoiditis or pure epidural disease, so on and so forth. So as we know that like malaria, similarly tuberculosis can present in any which fashion, and we need to keep our antennas on to pick up the disease. The usual presentation is gradually progressing back pain, and the disease is gradually progressive because extrapulmonary or skeletal or POTS spine is a paucibacillary disease. And so general dictum is a gradual progression with nocturnal increase. This is a red flag, nocturnal increase. So the minute you hear this, you need to start investigating quickly. The patient may at times present with radicular symptoms, though it's not very common. Also in, say, India or some African continent, the patients tend to present late, and they do come with neurological deficit or progressive neurological deficit. They may come late to you again with features of instability and deformity, and uncommon would be constitutional symptoms. So This is a brief list of the presentation of Pott's disease. Now, when we see an X-ray, this is a simple nomenclature. So when you say there is a knuckle, that means just one vertebra is involved with the disease. When you say there is a gibbous, then 2 or 3 vertebrae would be involved. And these two constitute basically angular kyphosis. So in deformity, there will be 2 types of kyphosis. One would be angular and the other would be rounded. So knuckle and gibbous would come under angular kyphosis. And whenever there is more than 3 vertebrae involved, then you call it a rounded kyphosis. So this is just to present you with the nomenclature. Now, when you get a patient whenever you are suspecting tuberculosis, how should you start investigating? Well, as with all back pains, be it neck pain, dorsal pain, lumbosacral pain, you start with an X-ray. Now, when you go in for an X-ray, please try and get oblique views as well. This is a take-home message, AP, lateral, oblique, because in oblique, you see the margins the best, and also you can see the posterior elements in a better fashion. So try to get that. But mentally, you should be aware that you have to pick up the earliest findings, because X-ray is a very, very poor, or X-ray has a very poor sensitivity of just say 15 to 20%, especially in early cases. So that is why you should study the X-ray minutely and try to pick the erosion and irregularity in the anterior superior margin. So there's something which I keep teaching, and that's the concept of white line. See, these are the white lines. So white line constitutes a normal end plate. And when you lose this white line, that is one of the earliest signs of loss or of end plate disease and something happening there, or tuberculosis. So I brought this X-ray. You see, there's a beautiful white line here. There's a white line here, and you see this as a loss. So try and look for white lines. And if you are finding a break in the white line or an absence, then you quickly investigate further. Then secondly, there would be disc space narrowing, because there is a paradiscal disease and end plate erosion. So despite the disc space being intact, still there is narrowing of the space. So despite the disc being fine. Now then you should always get a chest X-ray as well whenever you are suspecting, because 30 to 70% of these cases would have a lung lesion as well. So this was basically the X-ray and how you should proceed when you look for an X-ray. Then, as we all know, the imaging modality of choice is GAD MRI, and try to get focus on the involved area which you are suspecting with a single screen of the whole spine to pick up the skip lesions. So that is very important. Now, see, we get MRIs very often, and here I would like to give you a very important difference between modic changes and a MRI. Now, because many a times we get, we feel that there is an infiltration when there are just modic changes. So there is something called as a claw sign. A claw sign. This is very important. So if you are getting a claw sign, then it is suggestive of modic changes. So claw sign means that you have infiltrative pattern on the superior vertebra, which is going like this, and in the inferior vertebra, which is going like this. Say on T1, T2, whatever your combination is, depending on modic 1, 2, 3. Fine. So you get a GAD MRI. It has one of the best sensitivities and specificity as far as Pott spine is concerned. But you can also, and what I do in my practice is I try to get a CT scan done whenever I want to enter or when I step up the procedure towards a surgical management. So it helps me assess the joints, areas of calcification if there are any, and then overall destruction, whether it is focal destruction, osteolytic type, or whether there is subchondral erosions. So there are a lot of bony information that you can extract out from the CT scan. Now, as far as blood investigations are concerned, we should know what we need to get and what is the importance. So ESR per se has hardly any role as far as a diagnostic tool is concerned. It is more of a value of therapeutic response. So generally, the ESR levels is more than 20 in port spine, and then you keep on monitoring the ESR levels when you are providing the therapy. Something very similar for CRP as well. And then you have IgM, IgG markers in the blood. Now, this was like a test which was sort of marketed a lot, but now WHO has given strict guidelines to avoid, and it is not a recommended test. So kindly, especially in endemic areas, do not get IgM, IgG antibody test. Similarly, Montu test is not very useful in endemic areas, or when you have received BCG, it's not going to help. However, gamma interferon, for gamma interferon also, there is a ban on these investigations. So what are the main types of investigations? The main types include that we need a AFB stain of the material that we have taken out. So whether it is a biopsy or whether it is you have attempted a surgical procedure. So whatever material you get, you send it for AFB staining, send it for culture and antibiotic sensitivity. And as you know that BACTEC culture is one of the best. Then do a PCR of the sample tissue. This is again a very important test, especially for extrapulmonary tuberculosis, because PCR is much more sensitive than gene expert. Gene expert is more valuable for when you have a large load of bacilli. When you have paucibacillary disease, PCR is a very important test. Now in India, you know that gene expert is done almost free of cost. But again, you have to understand that when you are sending samples from spine, if the patient can afford, please get a PCR test. The chances of its sensitivity and specificity would be high. But suppose if you're not able to afford the test, then go in for a gene expert, especially, I'm not sure about the African continent. In India, it is done in almost all government hospitals and it is free of cost. So gene expert will tell you about Mycobacterium tuberculosis, and it will also tell you about rifampicin sensitivity. So this is the importance of the investigations. Now, coming on to the basic framework of management, what I want to emphasize here is please do not treat patients empirically. So you get a history, you get an MRI, and you start treating it empirically, thinking that it is tuberculosis. There is a very high, or not very high, I would say there is a 20% risk that you may be wrong if you're treating the patient empirically. So you see an MRI, you see the patient, and you start anti-tubercular therapy. That is not recommended at all. So please do not go for that. Try and get a biopsy or a PCR test. And if it is negative, if it is positive, you start your whether chemotherapeutic regime or surgical, totally depends on you, depending on the condition of the patient. However, if the biopsy and PCR is negative the first time, please convince the patient to get this test again, okay? Because you will be safer medico-legally. And the reason is that if you are treating empirically, there is a very high chance of a delayed diagnosis and aggravation of other types of different diseases, which I'll be discussing soon. So what are the differential diagnoses, say on MRI or clinical picture, which may mimic like pod spine? So you have pyogenic spondylitis. So typically you have an immunocompromised or a diabetic patient suffering from staphylococcal spondylitis. 10% of these patients would be having pyogenic spondylitis. So you need to diagnose that. Second is brucellar spondylitis, not very common, sarcoidosis, metastasis, lymphoma and multiple myeloma. So I must tell you that there are enough papers and lot of randomized trials where, or blinded studies where, you know, the images were shown to the radiologist, and in 20 to 30% of times, their diagnosis was not correct, whether it is, you know, A type of disease or B type of disease. And so it is very pertinent and important to get a tissue diagnosis prior to you starting antitubercular therapy. Now, this is again an important area which I want youngsters to take up. Please understand the chemotherapy. All patients of pod spine, you are going to give chemotherapy. Okay, there'll be only 10 to 20% of patients whom you will be operating. Fine, once the diagnosis is done. So you need to get involved in the chemotherapy of the drug and not just leave it to somebody else. Now, the question that I ask here is, why do you have 4 drugs? Okay, why not like any other bacteria, just give one antibiotic? Why do you have 4 drugs? And I'll explain you the reason. There are 4 types of Mycobacterium tuberculosis in the disease. So the first is extracellular and rapidly dividing bacteria. The second would be extracellular but slow dividing or intermittent dividing. The third would be intracellular, where the macrophages have taken up the bacteria. And you know, these bacteria have a proteinaceous layer which our macrophages are not able to kill or, you know, break. So there are intracellular mycobacteria which are dividing. Okay, and then there is dormant types of bacteria. So every disease would have these 4 types of bacteria inside the body. And that is why you have 4 different drugs. Why? Because rifampicin would be acting exclusively on extracellular slow dividing bacteria. INH, streptomycin, ethambutol would be acting exclusively on extracellular fast dividing. Okay? Pyrazinamide will act only on intracellular bacteria. So pyrazinamide would get into the intracellular component and then destroy the bacteria. It has nothing to do with the extracellular bacteria. Fine? And you have no antibiotic or drug against a dormant bacilli. It is lying, and we all have that, and whatever drugs we may take, you will continue to have dormant bacteria. So because the action of these drugs are at the different areas and different type of bacteria, so we need to have a combination of the therapy. I hope I have made this thing quite clear. Now, when we talk of, again, nomenclature about resistance, we need to know what is MDR, what is XDR. So drug sensitive means where arsine and INH are sensitive. So we have almost 80% of our patient group in pod spine who have drug sensitivity. Monodrug resistance would be either arsine or INH insensitive. Then you have MDR, multi-drug. We all know about it. We classify the patient as MDR if both rifampicin and INH are resistant. Okay, so you can label a patient MDR, though we label the patient as MDR clinically as well if we see a poor response. But the ideal way is when you have documented that there is resistance to INH and rifampicin. And then you have XDR, which is extensively resistant tuberculosis. So you have resistance to rifampicin and INH, you have resistance to one of the fluoroquinolones and also one of the injectable second line. So say, for example, amikacin or kanamycin, etc., etc. So that is how you have extensively resistant tuberculosis. And as late as 2009, we have completely resistant tubercular bacilli also, which is, I think, beyond us. We need to involve an infection specialist. So I have not brought that in here. It is rare, but it is still there. Now, to quickly show you, about 10 to 25% patients, which is a huge number, have some sort of resistance. Okay, either mono, MDR, XDR. Out of them, around 70% would be MDR. So just imagine if you have 100 patients, say for example, approximately 20 would be drug resistant. Okay, so out of 100 patients, 20 would be resistant to some drug. And out of 100, almost say 14 patients would be MDR. Fine. So we need to know, or try to know at least on day one when we are starting, which cases are MDR if you do not want to land up in a problem later. So that is why there is an importance of gene expert test. At least you get to know about rifampicin sensitivity. And second, backtech. Now, why backtech? Because it gives the resistance profile in approximately 2 weeks, which is the fastest as at present. XDR is uncommon, but still you need to consider there would be around, out of 100, 2 to 3 patients who would be XDR. Now, what are the causes of drug resistance? Again, you should be aware and involved with your patient, because inadequate or incomplete treatment will lead to MDR tuberculosis. So what is the clinical significance? The clinical significance is a patient coming to you who has been diagnosed, say, POTS spine by some of your colleague. He started anti-tubercular. Then this gentleman stopped taking drugs, or he, took drugs according to his whims and fancies, and now he comes to you. So please try to consider this patient as an MDR, because there's higher chances of him developing into an MDR. So try and investigate him fully. The second is group where there's poor drug compliance. Okay, he's taking for 2 days, not taking for another 4 days, and so on and so forth. Then we now know that there is a genetic predisposition for resistance to anti-tubercular drugs for particular drugs. So you will have INH resistance, and you have particular genes associated with that. Similarly for other drugs, okay? So there is a tendency of genetic predisposition. And also, if you have associated HIV, then it is important to consider MDR, okay? Because it is more common amongst immunocompromised and HIV patients. And we have a lot of these patients coming to us with tuberculosis now. Especially, I feel, in the African continent, though I don't have a clear data on this. So in all patients of suspected POTS, please get a HIV test also to sort of complete. And if there is HIV, then suspect a MDR. Now, what are the current recommendations? Current recommendations are 4 drugs for 2 months: arsen, INH, ethambutol, pyrazinamide. If you're not able to give ethambutol, then streptomycin. And then you continue 2 drugs for 7 months. Though WHO, British Council studies, there's still a lot of controversy and the jury is still out. However, what I've written here is, the sum and substance of most of the current research that we have. So 2 drugs for 7 months, fine? Now, I'll go to the second part of the lecture. If there are any questions, if the participants want to ask questions regarding the first part, John, do you want me to answer any question or just carry on? Hello?
Whatever you want to do, Ashish.
If I'll just wait for 30 seconds. If there is anybody who wants to ask a question, he's free, he can.
Yeah, there's a couple of questions here, Ashish. that have been asked.
Yes.
Okay, one is from Kartik. As you told, blood supply could be a reason behind involvement of end plates in TB. Likewise, what is the pathophysiology of METs involving more of post elements, mainly pedicle vertebral body junction?
Where can I see these questions? I'm sorry.
Oh, and the chat box. You have a chat box?
Chat box.
Yeah, click the chat at the bottom of the Zoom.
Okay, chat.
Yeah, click that. And do you see the question there? Please post.
Okay, fine. So part of I was asking important presentation. Can you read two questions?
It's at the bottom. The last question asked, actually.
Okay. So, Ninad is asking what is the sample for PCR? Well, the sample for PCR is the tissue. That is most important. So if you just send a blood, it is of no value. Okay, and PCR is best for, as I said, for paucibacillary disease, extrapulmonary disease. It is one of the best. So you need to send the sample for PCR. It is generally sent in normal saline along with gene expert. So you need the sample, tissue sample. Now, the second is incidence of pyogenic spondylitis that present as slowly progressive course, as usually they'll be acute with lot of toxic features. Fine. I would, this is a question from Karthik, and I would like to say that that may not be very true for all types of pyogenic spondylitis. What you have specifically mentioned is more of iatrogenic pyogenic spondylitis, where you have operated and then the patient develops spondyloid bursitis. When there is de novo pyogenic spondylitis, I agree that it would be faster, but MRI picture may be very similar, except for a lot of extravertebral disease, which is more commonly seen in port spine or purely a paradiscal disease. However, as we know that port spine can be central as well, and it can have other forms of presentation. I do agree that pyogenic spondylitis would have a little more acute course, but that may not be true in all, especially in diabetics, where the immunity is a little low, the patient comes to you with pain, so on and so forth. I very clearly remember a case of pyogenic spondylitis, came with neck pain, there was manipulation, and we missed the diagnosis till the tissue diagnosis right. Okay. Okay. The next question again from Karthik is, as you told, blood supplied to a reason behind involvement of end plates. What is the pathophysiology of METs? Well, pathophysiology again is hematogenous, Bateson plexus. That is very, very important, because a lot of disease for metastasis, as we know, is through the Bateson's plexus. So it's more of venous rather than arterial, as in or pure through the main arteries in port spine. So this is about the MET. If we stop AKT in view of hepatitis, then how early should we restart the regime, and should we give an extended regime? Okay, that's a good question. First of all, why do you want to stop AKT in hepatitis? You need, so there are two aspects of the answer. The first is, this is one of the reasons why we should avoid giving combination or pre-combined drugs, like say AKT4 or MECOX, as we get in India. We should give separate rifampicin, INH, ethambutol, pyrazinamide, and we know that which drug has what side effect profile. So we know that rifampicin can cause a hepatitis. So depending on the side effect or the complication, we need to withdraw one drug at a time, unless it's fulminant hepatitis or, and this is the time you need to involve your infectious specialist. So you need to try and continue, you need to withdraw the drug which is leading to hepatitis and continue the AKT. As far as extended regime is concerned, You need to monitor. Suppose if you're stopping one drug and you're starting another and the response is good, then obviously you need not extend the regime, the period. However, if you really feel that your ESR, CRP are not coming down, your MRI is still suggestive of progressive sort of disease, though these are indirect evidence and not direct evidence, then you can extend the regime. Okay, how to proceed with PCR and culture negative cases in suspected TB spine? Well, again, Harsh, this is a very, very pertinent clinical question, and this is very common, because the sensitivity of PCR would be around 80%. So again, 20% of the times you will go wrong. Culture negative, only 50 to 60% would be culture positive. And this is mainly because they are possible. The pot spine is a possibacillary disease. And for PCR to be positive, they have to have a bacteria count of more than 10 to the power 4. Okay, A per ml. So if the sample that you have sent does not have this much amount of bacteria, your PCR would be negative. Similarly, there is a value for culture as well. So the best thing is to repeat these tests. Okay. Now, coming to the practical aspect, you need to convince the patient that why you need to do this. You need to talk to your pathologist again that this is the issue and this is you need to relook. Okay, fine. But suppose if the patient is not agreeing for a repeat and he asks that you start the treatment, then please get a medico-legal consent that you had asked for a repeat test and the patient party has not agreed. Okay, so you need to sort of save yourself, but ideally nowadays the dictum is please repeat the test. So the test need to be positive before starting, because if the test is negative, you are back to the same place where you don't know or whether it is lymphoma or etc. etc. Okay, does CSF, PCR has any role? Definitely, if you have the disease in CSF, only then PCR would have a role. So if the CSF, or if there is no tubercular arachnoiditis, or if there is no tubercular meningitis, or the CSF does not have bacteria, then obviously PCR would be negative. Okay, then we have how frequently use gene expert. We send gene expert in all cases. So we do not sort of leave. So as per our dictum now, our protocol, all samples are sent for gene expert. And obviously, if you have rifampicin resistance, then you need to start or add one of the second line drug to the regime. So what we do is generally we involve our respiratory physician or our physician to assist us on the type of drug that he wants to use now. Because as I told you, rifampicin is acting on the slow multiplying bacteria which are extracellular. Okay, concomitant pulmonary tuberculosis, almost 30 to 70%. Gold standard for screening of pulmonary tuberculosis, well, one of the best would be to get a sputum done. And if the sputum is positive, then obviously you have, that is the true confirmation when you get a AFB and you get a culture done, so, or a gene expert. So that is the gold standard, but obviously you get a clue with a chest X-ray as well. The sensitivity is around 40 to 60%, especially it is low for the early cases. So I think I have answered almost all questions here, and I'll go to the next part of my lecture. Is that okay?
Yes.
Okay, fine. Okay, so what are the considerations when you go ahead with or step up your procedure? So one is questionable diagnosis. So confirm the diagnosis. That is very important, as I have been stressing time and again. Then you need to ask yourself, is decompression required? Is fixation required? What would be the safest approach? And whether you need 180 or 360-degree fusion. And finally, to add whether you need a kyphosis correction as well, okay, to add to this list. So what are the surgical indications? One is poor response to medical management. So I'll show you one of the cases. When you're giving a drug and still the patient is deteriorating, get into surgery. If there is a recurrent disease or progressive neurological deficit despite chemotherapy, so recurrence or progressive neurological deficit on drugs. Then if on the first visit itself, you find severe weakness, you can't wait any further. You need to act immediately. Incapacitating pain, severe pain because of spondylodiscitis, because of abscess, so you need to then enter, because anti-tubercular therapy would further increase the pain and the abscess in the initial 2 to 3 weeks. And finally, if he comes to you with a deformity, so you need to take him up for surgery. But overall, the surgical patients would be around 10 to 15, 20%. And still we practice what the middle path of Dr. Tully, where once you have a confirmed diagnosis, you give chemotherapy. That is your main treatment. However, in those who are deteriorating, you act surgically. So what are the approaches that we have? And I'll just quickly go through the various approaches which all of you who are practicing spine or pod spine should have in the armamentarium. Whether you use it or not is, totally depends on what your patient's need are or what you're comfortable in. But still, you should be aware of all the procedures. Approaches. So you have the anterior approach, you have the posterior, which is now the preferred approach. You have the posterolateral, some call it anterolateral, or a combined anterior-posterior approach, or there is global fusion, mainly through the posterior-only approach. Okay. I'll just dedicate one slide to posterior approach here. This is the most commonest approach these days, though there would be a lot of cases which I will share where I have gone anteriorly, but most of these cases have been of my previous years. So why posterior? Because we are familiar with this approach. We can achieve a good decompression even for anterior disease or anterior compression. There is a good chance of very good correction of the deformity along with decompression, and then you avoid difficult approaches or thoracotomy related complications. Now, quickly to share some of the cases, here she is a 26-year-old pregnant lady, severe neck pain for 4 months, restricted neck movements, neurological deficit with hand weakness and tingling sensation. Now, she came to me like this: pregnancy and severe compression and progressive deficit. I advised surgery, she refused. The family refused. However, we started on anti-tubercular therapy. This was an empirical therapy. This was about 10 years back, 10 or 8 years back. We did not go in for a biopsy. The patient was lost to follow-up for 4 months. She continued anti-tubercular therapy, delivered a healthy baby, and returned to us for further treatment with neck pain. And this is the MRI picture. Her complete pus is almost resolved, but there is instability. So what we did in this case was we went anterior through the retropharyngeal approach, did a quick odontoid excision, and then we followed it up with a C1, C2 fixation. Okay. So this is what we achieved. The patient did extremely well. Then next case is a 32-year-old. He's a vegetable vendor. So hawker with neck pain, restriction of neck movement for 5 months, progressive disease, stiffness in lower limbs, tingling, no bowel and bladder symptoms. And he came with the anterior and posterior disease. Again, this is a typical straightforward case. Now, if you look here, there are two problems in this patient. One is an anterior as well as some posterior disease. There is building of kyphosis, deformity, and we achieved decompression with a large graft and a reasonable kyphosis, correction of kyphosis. And he is he did very well. As most of the port spine patients went back to his job. This is a very interesting case here. The 60-year-old female, persistent dorsal pain for 3 months, nocturnal increase. She underwent serum electrophoresis, CT chest, abdomen, which was not contributory. The CRP was raised. This was the disease. So we needed a biopsy. We went ahead. We did a transpedicular biopsy, which came out positive for POTS. Now, if you look at the disease, this was a typically localized disease, no compression, no significant destruction. We started her on anti-tubercular 4-drug regime. However, patient gradually kept deteriorating. She became bedridden over a period of 6 to 8 weeks, severe stiffness and weakness. And when she came back to us, she came with this picture. Okay. Extensive increase of the disease on 4 drugs. We went in quickly, went in for an anterior transthoracic endoscopic assisted approach for 2-level corpectomy. This is what we did. She did fairly well. We thought it to be, though again at that time we did not have a direct evidence of MDR, but looking to the clinical profile, we continued ATT for 18 months. She has now over 18 months started walking with support, and the catheter has been removed. This is another lady. So I'm trying to get different areas and different types of presentation. Here it's altogether a different case. 40-year-old lady operated for port spine 12 years back when a laminectomy was done. She remained well for 10 years, and now she came back to us with this picture of lower limb weakness and stiffness. And it was quite a stiff curve. And this was the MR axial. We went in for a thoracoabdominal approach. We felt at that point of time we were not very good with 360-degree posterior approach. So we took a thoracoabdominal approach with excision of the internal salient. So this is what we could achieve. This is the simple screw rod instrumentation. Okay, another lady, 40-year-old, progressive dorsal pain for 6 months with radicular symptoms, mild weakness in the lower limb, miliary tuberculosis, D9, D10 disease, and we used extended cost transversectomy. And I just brought this to show the approach for extended cost transversectomy, which would be something like this. A 45-year-old gentleman. Okay, what is this? Yeah. Now, in this patient, we did, unlike the previous patient, we went in for a lateral extracavitary approach, which is LECA. And this beautifully depicts that when you go just by midline or when you use transpedicular, you would be able to approach this. However, anterior decompression would not be very, very good. better with costotransversectomy, and excellent with lateral extracavitary approach, which is an extra pulmonary approach. So you sort of push in the pleura, and this is, you can fix it, you can decompress it. It's an excellent approach, especially for the mid-thoracic area. You take a T-shaped incision, dissect the posterior elements, expose the ribs, and then you basically cut out part of the rib, push the pleura down, and then attack. Decompress the whole part. You can sacrifice one root in the thoracic region and then fix it. Okay, this is a dorsolumbar disease. I think a straightforward case. We did a posterior decompression and then fixed it. Nothing extraordinary about this patient. This was a follow-up after 6 months. The deformity has been stabilized. This is another case wherein, this is another case with infiltration, and I brought this again to show you the difference between modic and infiltration. So if you look here, there is gross infiltration, okay? In modic, you have a claw sign. So there'll be an infiltration like this, or I would rather say MRI changes in the upper vertebra like this and in the lower vertebra going like this. So again, forming a claw. So whenever you see claw, just go through all the MRI sequences and consider more modic changes. But however, if you get gross changes, abscesses, discal degeneration or paradiscal involvement, do think of infective process. So in here, again, we went through, we just did a biopsy, a transpedicular biopsy, and started on treatment. This is a lady in her third decade, progressively increasing lumbar pain for 6 months, not able to turn in bed. That means very severe weakness now, pain. And this is how she came to us. And again, a typical lumbar disease, simple posterior decompression. I think we supported with grafts in here and fixed. Another with a deformity. So this I think I had discussed with all of you in the kyphotic lecture on kyphosis as well. And this was the MRI picture. We did a posterior complete vertebral resection and used an expandable cage to support the spine anteriorly. Okay, so I think it's, what time is it? Okay, already almost an hour. So what are the...
Take as much time as you want.
Yeah, this is my last slide, and then we are open for questions.
Okay, good.
You need to have a high suspicion of the disease, especially if you have a red flag in the history. So red flag would be nocturnal pain, dorsal pain, which has been progressive, gradual progressive disease. If you have constitutional symptoms, if the patient has some other stressful conditions in the past or present, diabetes. So keep your, again, you need to have a wide sort of a view in making the diagnosis. Second, very important, please, in all cases of chronic back pain, neck pain, look for early changes on the X-ray. So don't miss that. Try to avoid empirical treatment. I've already told you, though many times it will be difficult, but make it your personal dictum to avoid empirical treatment and try to confirm the diagnosis. Then have your personal involvement in drug management. You should be aware of the drug dosage. Here I would tell you my take. I try to use the maximum drug dosage. Okay, so for example, say INH is 5 milligram to 6 milligram. I'll rather go 6 milligram per kg. Similarly, ethambutol, if it is 15 to 20, I'll rather go for 20. Pyrazinamide 25, 30, I'll rather go for 30. Okay, so I'll try to go for the maximum safe dose. and then assess for side effects and complications, rather than going for the lower dose or a fixed dose. That is not good. Get a weight of the patient and give the drugs according to the weight. Then, when you initiate the treatment, please inform your patients about the risk of MDR so that they are aware and have it documented. So that in the future, almost 10 to 20% of your patients would turn out MDR. So you know that you have already explained it to them, and they are more ready to sort of escalate the treatment and continue it for a longer period of time. Or you may need to go in surgically once again, extend your fixation, so on and so forth. And then, as I have showed, a wide armamentarium of surgical approaches in your kitty to manage this very important disease and very common disease that we encounter. Once again, thank you for this invitation and coming for this webinar. I hope I've been able to provide you with some unanswered questions. Thank you.
Great, Ashish. I'm sure we have more questions, and especially Karthik, if you want to come on camera. Karthik, if you want to come on camera, I'm going to get you off the screen share, by the way. If you want to come on camera, Karthik, you seem to have a lot of questions, and you're obviously a neurosurgeon or a resident. Oh, there he is, Karthik. You want to ask your questions direct? You got to unmute yourself. We can't hear you.
Hello, can you hear me now?
Yeah, can you hear him? Can you hear him? Okay.
Sir, regarding the operative management.
I can't hear you very well.
We can't hear very well.
Hello.
Yeah, we can. That's better. Better.
Yeah. Sir, regarding one of your operative regimens, what is the indication for standalone laminectomy without instrumented fusion in a case of pot spine, as like it will be a predisposing factor for promoting further deformities? So any particular indications to just get a laminectomy and decompression and come out without instrumented fusion?
Yes, absolutely. So as you know that if there is a small group of patients where you have a posterior alone disease, so only the posterior arch would be involved first. Second, there would be a group of patients where you have just posterior epidural disease. Okay, it can be short segment or long segment. So in this group, if it is a short segment disease, I would just go in for a laminectomy, get the tissue and start treatment. So again, the important point here is that if my anterior elements are stable, non-diseased, and if only the posterior elements are involved and there is a short segment disease, I'll just go for laminectomy. That is number one. Number two, as you are aware, when I'm not sure of the diagnosis, okay, and there is compression posteriorly, okay, so then again, my first, and there's no anterior involvement, I would go in for a posterior laminectomy, and be it tumor, abscess, whatever, I'll just do it.
Yeah, sure, sir. Thank you, sir.
Okay, more comments, questions from the panel?
There are some questions. I'll just go through them.
Yeah, okay. Just pick out the relevant ones.
You use it for determining this. Why do we still do MON2 regularly? Still see a lot of institutes doing it. Oh, yes. Yes, Rahul. Many of us and many institutes do MON2, but in endemic areas with BCG vaccination, it is not. It will not help you either way. So I don't see a great point, and there is not a strict recommendation. Though I think I'm not very sure. I'll come back to you if you'll send me your email. I'll do some more research on this, and I'll come back to you whether there is any sort of advantage in endemic areas. But as of now, what my study says is that in endemic areas, it makes no difference.
Let me just interject one thing. Someone asked for a copy of your PowerPoint. What do you send that? Do you do that or not? I don't know if that's common.
No, if they want this presentation.
Yeah.
Oh,
yeah, someone asked, how do I get a copy of your PowerPoint? Now, I don't know if that's normal to ask that or not.
No, I don't mind if it helps them. They can. Also, I think we are putting them up on YouTube, right?
Yes. Oh, no,
Yeah.
this is Facebook now.
Oh,
We're on
okay.
Facebook today.
Or what, if you can write an email to me, I'll just send it to you. So it's for you, boys.
Yeah,
you want to have it, no problem.
okay, what I'll do is I'll ask people, if you want to get a copy of the PowerPoint, put your email in the chat box now, and I'll give it to Ashish. Does that
Okay.
sound like a plan? Okay, yeah, there's someone sent an email here.
There's one
Yeah,
question.
I've got a couple emails. Before you go, Ashish, please remind me, okay? Okay, there seems to be more questions, and this is a good teaching thing, and we're not tied to an hour. If we have
Okay.
good teaching, we'll just keep rolling. Okay.
So Ninad has this question: other than no instability, what are the indications for not to operate? Other than no instability, what are the indications for not to operate? What's Ninad? Can you reframe your question? I'm not able to understand that. This Karthik's question I have already answered. Rahul, what is your follow-up protocol? How early you can identify drug resistance? Early. Okay, this is a good question again from Rahul. Rahul, well, we have two distinct ways of suspecting drug resistance. Once when we know from the backtech or gene expert that there is a drug resistance. The second, if you go through literature, there are set, I'll say, criteria where you need to suspect drug resistance. So one is, if, for example, if you're giving treatment for more than 4 months and the patient is not responding, or there is a recurrence of the disease. So these are the two more important of the clinical way to suspect drug resistance. The third is there is persistent sinus. So you have operated and there is a persistent sinus. So these are some clinical ways. However, at least if you do not have the culture, and clinically, at least you should continue the treatment for 3 to 4 months before clinically confirming that there is drug resistance. Any reported cases of instrumentation failure at the level of the pathology? So Dr. Asil has asked this. What does he want to ask specifically in port spine? Because see, instrumentation failure can happen in any pathology. So do you want to ask something related to port spine? So if you have, you can just ask me the question again. Then Rahul, patient with concomitant seropositive HIV, how would you treat? Which to tackle first? Okay, they go hand in hand. We have a WHO guideline for anti-tubercular regime with HIV, and you need to suspect them as MDR. Also, you need to treat them as MDR with adding a fluoroquinolone or a second-line drug. Again, there are guidelines for it, and you need to follow those guidelines. So you treat hand in hand. Okay. How common is implant failure owing to MDR? Well, Jitin, again, this is a very practical question. If you have multi-drug resistance, rest assured that there will be problems with your implants, because the fusion is not happening. There is pus around there, and there is a very good chance of your implant failure. So you need to treat it aggressively, and don't hesitate in going inside once again, extending the fusion, so on and so forth. And if there is a particular level failure, just go above or below. So it would obviously more common in MDR disease. Follow-up of these patients, how often do we need to do MRI? Only ESR would be enough for follow-up. Okay. Well, follow-up, I'll just bring your attention to, again, very nice paper by the Abhay Nene group. And they have shown, and this is a very, very interesting study. Now, what happens is, and this is very common, that say at 8 to 9 months, the patient is totally symptom free, but on MRI, you keep seeing lesions. Okay. Now, at this point of time, you feel that, oh, the disease is still there and I want to continue the treatment. However, this group has shown that when you stop the treatment at 9 months to 12 months, even if there are changes on MRI, there is a very, very high chance of that resolving on their own despite stopping the drug treatment. So MRI can be dubious. Okay. So if your patient is improving clinically, his ESR, CRP are improving, then you can stick to 9 to 12 months and, or say 9 months. And this concept that despite the MRI not being very clear, you need to extend the regime does not hold true now. Okay, Rahul, I'll send these if, okay. Indications for only medical management. One is no instability, others. Okay, see, 80 to 90% of the disease has to be managed medically. Okay, so for example, if the patient has mild deformity of less than 10 degrees, you don't jump in, despite feeling that, there is instability. Okay, so in most of the cases you go, so if there is a mild weakness, which is stationary, don't go in for surgery. Okay, then I would say, yeah, so basically stable neurology and a relatively low level of instability, you continue medical management apart from no instability. I meant to ask if there's a higher chance of instrument failure at the level of in comparison with adjacent normal levels. No, that is not true. There was a very, very important study, ASEAL, from Olga et al. And they clearly showed that in pot spine, the bacteria, mycobacteria, does not form this, this membrane. Okay. And so the anti-tubercular treatment that you give reaches to to very near to the implant as well. So it's not that if you have, this is the implant as in pyogenic, and there is a membrane created by the bacteria and the antibiotic is not able to penetrate. So the bacteria keeps on growing around the, I'm sorry, around the implants. That's not true for pot spine. So if you're suspecting pot spine, you can very easily put in the screws at the pathological level. And in fact, you, especially say for lumbar levels, you are able to prevent the motion segment. So that is very important. Any role of steroids? Yeah, absolutely. As in tubercular meningitis, tubercular spondylodiscitis as well. There is a role of initial steroids. It decreases the pain. There are few studies which say that it helps penetration of drug, but it's not not a very good type of study. And we have also come across patients where after initiation of antitubercular, if his pain increases, steroids do help in sort of helping the patient clinically. So there is a role of steroids, and I myself tend to use it for a short period of time, not for long. Yeah. So I think any more questions? There was one.
Yeah, look through that, Ashish.
Yeah, I think I've answered all. If there is any if I haven't answered any, or if I missed, please do ask once again.
Okay. Yeah, does anybody in the panel have a question in any area that Ashish may help you in?
Rahul, what is iris? I'm sorry, I didn't understand this. How do you identify iris? Is it resistance or what?
I don't know what iris means.
Rahul, okay. In LECA approach, it's unilateral approach. So what type of fusion? Plate and cage only. Okay. So for Nina, LECA is lateral extracavitary. So I have a line incision. You just put in your screws, and then unilateral go and you sort of put in the cage or graft. So it's a 360-degree approach that you can take up, and it is very good. You put in, you can either put in plate, but putting in a plate tends to have more exposure of the body, so I would rather just put in pedicle screw and support it with a cage anteriorly. Rahul's question is immune reconstitution inflammatory syndrome.
Oh, that's
Rahul,
what
I'm
Iris
really
stands for.
sorry
Yeah, that's what Iris stands for.
to you with this. I don't have an answer to it immediately. I'll come back to you. Immune reconstitution inflammatory syndrome. I'm really sorry. I won't be able to answer this at this time.
Okay.
I'll look through the literature and perhaps I'll try to come back on this.
Very good. Well, thank you, Ashish, for taking the time, and thanks all the panelists. And we had a good amount of interaction, which is the purpose of this, Ashish, is interaction. We're not just watching a video, we're interacting with you. So stick around for the next hangout, next webcast, and we'll see you next week. Ashish, thank you.
Yeah, so thank you. Thank you so much. Thank you, everybody. Bye-bye.
Okay, I'll edit this and we'll divide it into two videos. So we'll start the next one. Ahanga, are you there? It's the next presentation.
Yes.
Ahanga, can you hear me okay?
Yeah, I'm here.
Oh, great. Okay, I got your PowerPoint. You're ready to start? Okay, I'm gonna introduce you, okay?
Yeah.
Okay, hold on, let me get myself on the screen first. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, home of Neurosurgical TB. We are graced with the presence of Ahanga from Uganda. He's a neurosurgical resident. He's going to tell you about the title of his work involving glioblastoma in low resource companies. So welcome, Ahanga, it's all yours.
Yeah, thank you, sir. Thank you so much for this opportunity again. Can you hear me?
Yes, we can hear you.
Okay. Thank you for everyone who is here for this webcast of this evening. This evening, I'm going to talk about glioblastoma multiforme, which is a kind of a primary cancer of the brain. So I sent you my slides. You can.
Yeah, let me share it. Okay.
Yeah.
Okay. Okay, you can you see it? Okay.
Yeah. Yes.
Okay. Tell me. Okay.
Yeah. I'm going. I'm called Eyanga Idi Marcel. I'm a resident, a training in surgery at College of Surgeons of East Central and Southern Africa. I was in Uganda. So we are going to talk this evening about the challenges we have in glioblastoma multiforme management in low-income countries. Next slide. Next slide, please. Yeah. As this evening, I'm going to talk about my outline. I'm going to give a brief background. I'm going to give method and objectives, some results we got as this presentation is a case report. So after we have conclusion and some challenges, as well as a take-home message. As glioblastoma multiforme is the most common and the most malignant variant in the wide spectrum of intrinsic brain tumors, and is known as a high aggressive and generally lethal brain tumor despite aggressive treatment. Because for treating it, we need an aggressive treatment, but already it's aggressive and highly lethal tumor. And the bad thing for it, it occurs, especially in the elderly population who are already with multiple comorbidities and tend to worse than in non-elderly patient. But we can have this GBM in also in young people, in children. We have a form of GBM which is occur precisely in the fourth ventricle. Next slide. Yeah. I want this evening to highlight that the patient with a GBM is simultaneously a patient with a cancer and one with a progressive neurological disease. More than 10,000 new cases are diagnosed every year in the United States, according to literature. The incidence of GBM increases with the age, as I told, and the median age at diagnosis is 64 years. Surgery and radiotherapy in combination with classical alkylating agents such as temozolomide offer little hope to escape the poor prognosis due to GBM. Next slide. So for these reasons, enormous efforts are currently devoted to refine in vivo and in vitro models with the specific goal of finding new molecules, aberrant pathway for GBM, suitable to be targeted by a variety of therapeutic approaches, including pharmaceutic formulation and immunotherapy strategies. But the treatment to ensure prolonged survival while maintaining quality of life has always been challenging, as GBM, which glioblastoma, occurs mostly in elderly population with other comorbidities. So it is a little bit challenging in this population to survive glioblastoma. Next slide.
You got it?
So according those brain tumors, we have these intracranial tumors cause generalized and focal symptoms, as we know. Those generalized symptoms reflect a progressive increase in ICP and include headache, particularly in the early morning, that is characterized by progressively increasing severity. We have nausea, we have vomiting as general symptoms of intracranial pressure due to, like in this case, due to tumors. So Mental state changes and hemiparesis can also occur. Focal symptoms depend on the tumor location, in which lobe where the tumor is. So these focal symptoms will depend on the location of the tumor in the brain. And for those cerebellar tumors, therefore lead to ataxia. Occipital lobe tumors result in visual field disturbance, and the tumors in the posterior aspect of the frontal lobe affecting the motor cortex will result in weakness, as they are affecting this motor cortex. So we can have seizures in these tumors, which are common and may be focal. Postictal neurological impairment may also help to get the localization of these tumors, as well as investigations. Next. So we tried to classify these intracranial tumors in two groups, where we have intracerebral tumors and extracerebral tumors. So these intracranial tumors will have gliomas, which accounts for 45%, including astrocytomas, oligodendrogliomas, and ependymomas. And as they start intracranially, intracerebral, they are intracerebral. We call them they are primary tumors because they are not metastatic. They are not coming from another site beyond the brain. And we can have also lymphomas, pineal gland tumors, and we can have metastases, which are secondary tumors. So extracerebral, we have meningioma for 15%. We have tumors of cranial nerves. For example, we have vestibular schwannomas for 5%. We have pituitary tumors for 5%, including pituitary adenomas and craniopharyngioma. But in this presentation, we are focusing on glioblastomas, which are our topic for this study this evening. Next slide, please.
Okay.
And we are saying that these gliomas arise from the glial supporting cells and are usually supratentorial. They are classified according to the principal cells components, and we can have astrocytoma, which arise from astrocytes. We can have
we are saying that these gliomas arise from the glial support.
Hello, Dr. Bennett.
Sorry about that. Next.
No. There was a little bit problem.
Yeah, okay.
So we can have these astrocytomas, we can have oligodendrogliomas, we can have oligoastrocytomas as a mixture of the two first types of tumors. As I said before, we have a rare fourth type of these glioblastomas in essentially in children, and this arises from the fourth ventricle, especially in children. Next slide. Yeah. Our objective and method we are going to use, as I said, it's a case report we are giving a patient we had in my practice 5 years ago. So we are going to focus on the incidents and challenges regarding glioblastoma management in low-income countries. As method is a retrospective study using a case report of a 45-year-old female who came to our consultation with history of progressive severe headache for 1 year and was treated like suffering from like malaria. You know, in Africa, some regions are endemic for malaria. So she was treated like that. And she had also forgetfulness, disorientation for 6 months, and the seizure since 2 months. Then she came to our consultation on upon these symptoms, these complaints from the patient. We went for a clinical examinations and we got some findings which sent us to ask for some investigations. And if investigation were done and we got a diagnosis of HBM. Next slide. So on our clinical examination, she was of a general condition which was fair, conscious. She was conscious, slightly disoriented. There was no fever, no more vital signs, and neurological examination noticed dysphagia, cognitive impairment, but no motor weakness. And as I told previously, that as in temporal lobe, this could cause motor weakness, but in this case, there was no motor weakness. So as investigation we did, this patient was evaluated with routine blood test, and we did also an MRI brain, and she was found to have a multifocal glioblastoma left temporal region. And all these blood tests, this complete blood count, basic metabolic panel, electrolyte, CRP, and the coagulation profile were unremarkable. Only this MRI brain which showed that she had this multifocal glioblastoma in the left temporal region. And we did other investigations. We did CT of abdomen, pelvic, chest to look for maybe a primary site to exclude a metastatic origin of this tumor in the left temporal region. Next slide. So you can see here these images which are here. The images from the MRI we did, and we found in this left temporal region these lesions which is here, and our differentials included metastatic disease to brain, lymphoma, and maybe or abscess. So we did, as I told, this metastatic workup to look for primary malignancy. We did chest, abdomen, pelvis, and was negative. This metastatic workup was negative because there was no other problem anywhere. Only in the brain, the tumor was there, which showed that the brain is part of the temporal lobe. Next slide. So after this investigation, that it was in the patient was brought to us in an emergency condition. We decided to do an emergent surgery for tumor removal. And it was the left temporal craniotomy we did, and gross total tumor excision after taking the consent from the husband, because the wife could not, was not current to take consent. Patient, for according to the technique we used, the patient was positioned in supine position with the head laterally, left side was up, because we were about to work in that region. So skin markings were done after shaving in the left temporal region. And aseptic measures a 2 to 3 centimeters line along the left supratemporal line was made. We made the incision, and the left temporal bone overlying the tumor was exposed after retraction of periosteum using the periosteal elevator. The bleeding from superficial temporal artery was controlled. Next slide, please. And we did barrel using and with drill in the temporal bone for removal. After exposing the dura was opened using micro scissors, and underlying middle temporal lobe gyrus was revealed. Then, by bipolar cautery, we create a window in the cystic mass with yellow tumor fluid oozing out of the center of the mass. So we had a view through the microscope, and the wall of the cystic mass was infiltrated infiltrated, and we did a border between the tumor and the seemingly normal tissue created using this bipolar cautery. Next slide. So the tumor was circumferentially dissected and removed. Tumor resection side cavity inspected for residual tumor. And by this inspection, we saw that all the tumor was resected and removed. So we dilute hydrogen peroxide soaked cotton ball in the cavity to augment the hemostasis, and also these seem to have a tumor residual effect. So the dura was closed, and the duroplasty completed with synthetic agent, and the bone flap was re-approximated, and satisfactory resection of the tumor on the postoperative MRI was seen. After the surgery, we performed it, and we saw that almost 96% of the tumor was removed. Next slide, please. So here we have some pictures, intraoperative pictures. As I explained, the operative team is there. We did, and the operation was done, and the postoperative MRI was satisfactory. Next slide. So during the operation, we did a brain biopsy from the left temporal lesion, and we sent for pathology, and the result came to us a few days after that showed the cells which were large to medium sized with hyperchromatic nucleus in sheet against glial background. There was moderate nuclear polymorphism and few mitosis with small foci of necrosis. Numerous vessels, and this glioblastoma multiforme grade 4 of WHO, which is the highly aggressive one with a very bad prognosis. So next slide, Dr. Bennett. So afterward, the operation, after the result, before the operation, the family was informed about what the prognosis and the plan for treatment. And the plan for treatment was after the operation, the patient would be under radiotherapy combined to chemotherapy with temozolomide, which is an alkylating agent. So previous slide, please, Dr. Bennett. Previous. So what happened is in these parts of the world, please, previous, this is the last, previous. Again. Okay. So where we did this operation, which was in Congo, and the time for the patient, this patient was discharged home after testing all functions. The patient was recovered all functions after the operation, and we planned for radiotherapy and chemotherapy. So the time for the patient to get medicine from abroad, because the medicine when for that the time this time we did the operation, we could not find the medicine locally where we did the operation. So they had to order this medicine from abroad, and the time to waiting for the medicine, the patient again is 1 month after the patient had a remission, and the patient unfortunately didn't survive this problem. And as our conclusions, outcomes still bad for glioblastomas. Outcomes still bad due to lack of adequate facilities in these parts of the world, in low-income countries. Radiotherapy and chemotherapy are not available for everyone, but this glioblastoma can concern every single one. So, and also there are in some areas, ignorance. Patient will not present to you on time. Most of patients will come to you when we are at advanced stage of the disease, and the prognosis at this period will not be good. Management of GBM is multimodal, as I told, combined surgery, radiation, and chemotherapy. However, temozolomide alone may be one of good alternative, but also again, sometimes we don't have it. We have to order it from abroad, and the disease will not wait. In low-income countries, in spite of excellent surgical treatment like given to this lady, lack of above-mentioned facilities makes the outcomes remain bad due to poverty. And I want to draw our attention, because if these glioblastomas are diagnosed in advance, we can, with good surgery, and if also radiation and chemotherapy agents available, we can just hope to increase this survival time. So it's an example in your house. You are feeding this small lion. The small lion is growing, and one day this small lion will become a big lion, and this big lion will eat even the one who was giving the food to the lion. It's the same example for GBM. GBM, the better treatment, if discovered earlier, low-grade gliomas are operated, are treated by this combined radiation and chemotherapy, and we can expect getting maybe good treatment. But in this part of the world, as I said, these agents are not available for everyone. You are to spend if they are not available locally. And also many cases are not diagnosed on time, as I told, and some others ignorance the bad diagnosis, and then when they arrive in good hands with your MRI, you have a good diagnosis, but again the poor outcome. Next slide. So here we want to acknowledge with a special recognition to Jacobs Publishers for supporting for this work. This work, you can find it on Google. We published this article at Jacobs Publishers, and in the article there are many details we could not say in this short time. So we declare here there is no potential conflict of interest with respect to research, authors, or publication of this paper. Next slide. Yeah, as a take-home message, we want to recall to our governments, especially in Africa, our governments and partner organizations like WHO, that they should encourage in providing with resources to facilitate research and training according to neurosurgery field. We want to highlight here tremendous efforts from College of Surgeons of East Central and Southern Africa, COSEXA, with its partners in providing neurological and neurosurgical training in Africa. COSEXA is doing a great job in training surgeons in Africa. So countries, governments, and these partners organizations would look on what COSEXA is doing and support this great job done with COSEXA in Africa. And but the by the statistics still showing that in Africa, one neurosurgeon, please, takes care of about 5 million populations. In contrast to what is in developed countries, where one neurosurgeon is there for about 200,000 population. You can see this gap in Africa. One neurosurgeon for about 5 million. Training and then a need. This shows that the need of training, as I told, is great in Africa. So those organization, neurosurgical organization, and I'm thanking here Dr. Pedro Viesco. I saw him here, is with us. He's one of my mentors. So in Africa, we have still a great job in training neurosurgeons, supporting COSEXA in this job, supporting research in Africa. We need this. Next slide. Dr. Bennett, next slide, please. And here, I'm thanking you for hearing from me. And this is the operating team. On your right side, it's Dr. Randas, who's a neurosurgeon, a senior consultant neurosurgeon from India. In the middle, your humble servant, Idi. And at my right side, we have our scrub nurse who help us for this job in this. So the question is, this question has to be answered for everyone. What is the importance of operating someone with a very short survival time after the operation? And again, why to operate this patient? It's a question I want, maybe Dr. Pedro can give some answers for this question. And that is the aim for this paper. We want from seniors to give some explanation for this. And again, thank you so much. This is the end of my presentation. Thank you so much, Dr. Bennett.
Okay, great, Ahanga. You're a published author and just a resident, the third-year resident. That's great. I have a couple of comments, but let's open it up first to the panel to see if anyone has any questions or comments regarding your talk. Anybody want to ask a question or share some thoughts with us?
Dr. Ben?
Yeah, go ahead. Go ahead, please.
Sorry, can you hear me?
Yes, we can hear you, Andrea.
Okay, sorry. Am I allowed to speak?
Of course.
Okay, well, first of all, my name is Andrea Brunori. I am a neurosurgeon from Rome, Italy.
Welcome.
Okay, and first of all, I'd like to congratulate with Marcel, with the African colleague, because I understand they are doing really a good job in very difficult conditions.
Thank you so much.
My question for you is is about informed consent. What is your policy there in Africa and in developing countries about informed consent? Do you get, do you acquire informed consent from all patients? Do you allow relatives to sign the consent on behalf of the patient or whatever? I tell you this because when I started my career back in the early 90s, even in my institution here in Rome, which is the capital of Italy, I remember that the informed consent was a sentence on the report, on the medical report, in which the patient would declare that he would allow a surgical operation on himself, and that's all. Is your informed consent form a detailed one? Is people able to understand from the cultural point of view, informative point of view, the difficulties of the cases, the disease, and the surgery? So what is your attitude? What is your policy in this field?
Excuse me, Andrea. This is Dr. Bennett, the moderator. Unfortunately, Ahanga has dropped off. As you know, there are some internet challenges also in Uhanga. This doesn't have, he went through the whole presentation without a hitch, and I was keeping my fingers crossed. But if we hang on for a minute, because I hate to ask you to repeat the question, but just wait a minute.
I'll try to be.
Yeah,
I'll
just
try
wait
to
a,
summarize.
yeah. Wait a minute or two, okay, Andrea, and
Of course.
he'll come back. He'll come back. Oh, there he is. Okay, Ahanga.
Hey, Bennett.
Yeah, yeah. I'll let Andrea summarize his question to you. Okay, can you hear me?
Yes,
okay, can you hear me?
Yeah. This is Lekuya. Can I
Well,
answer this question because I see Ayanga is out, off?
Yes. Okay.
Is he on?
So thank you, Dr. Andreas. So me, I'm Dr. Lekuya, a neurosurgery resident based in Uganda.
Yes.
So what we do
yeah.
We used to have what we call family conference. We don't really consent the patient alone, but we would like to have the entire family to be around, and we discuss to explain them all the possibilities of treatment available in our setting, but also we let them decide which way they want to take. Of course, most of them, they will choose to have surgery, but we will also, after this, document in details what we discuss with the family. We will have the consent form signed, but we'll also add an additional sheet, which we call family conference consent, like kind of everyone going to ask questions, and we also going to give them also some answers, and everything happening, we usually document in additional paper that we attach to the consent form. That's usually what we do in terms of brain tumors that we really know basically the outcome may be challenging and medical legal issues. And we used to do that to additional to the consent form, we add a family conference report. I hope I answered this question.
Yeah, nice. Thanks. One very short one for you. I've seen you do not drape the microscope.
Yeah.
You don't put a drape. How do you sterilize the instrument?
We used to have a drape in the microscope. We have a clean covered non-usable drape, which usually it's transparent. But I think that picture, it was, I think I'm not the one who operated. Yeah, that was a younger who is still off. I don't know if he's back.
No, he's not back.
But usually we have it. Maybe it was a special circumstance that they couldn't make it well.
Mhm. And okay, well,
Yeah, Andre, ask
because
him.
I remember
Go ahead.
in
Go ahead.
the
I'm sorry.
past, yeah,
Go
I
ahead,
remember
Andre.
people seeing people, but many years ago, sterilizing the microscope by formaldehyde and not draping the instrument. Maybe that's the way they do it there sometimes. Third, and then I will be. I'll shut my mouth.
No, we have lots
I
of time,
promise.
Andrea. We have lots of time.
Yes, but
Third of all,
currently,
a short comment and a suggestion, if I'm allowed.
Yes.
Why do you operate standing? Why don't you sit? It's more comfortable for long surgery to sit. You are more stable. So consider the possibility to operate sitting on a stool instead of standing. You'll see it adds a lot to the microsurgical operations.
yes, that's a good suggestion. But also we have some challenges of the type of microscope we have in Africa. You know, I think you should be familiar with our microscope, and the mobility sometimes it's if surgeon thinks it's better have you should be standing up so that you may control and your own movements with your assistant, because the microscope depends, sometimes it's fixed with the assistant. So if you sit, you can't have your assistant sitting. That's the challenge. But I agree with your suggestion also. That's really what we need to do.
Anyhow, congratulations. You're doing a great job.
You know, Andrea, I'm Dr. Bennett, the moderator. I'm not a neurosurgeon, but I would like to make a comment here. I was speaking with a neurosurgeon this morning about standing or sitting, and she was mentioning that Juha Ernest-Niemi, he likes to stand. He'd rather stand for long periods of time. I don't know if that's not too common, is it, Andrea?
Is not common at all. I must say.
Okay.
He's a superstar.
Yeah, I know.
He's allowed to do everything he likes. It's like saying, Messi strikes the ball in this way, but all the other people does it in a different way. But that's not the standard ever.
Yeah, another thing that was mentioned was that every morning Juha gets up and does a headstand. And I don't know, I couldn't do one. I'm in decent shape, but I can't do a headstand. And he does that for the strength of his fingers. Have you heard things like that, Andrea?
No, I haven't.
No, okay.
Really, I haven't. No,
okay.
No. Maybe he wakes up very early, probably.
Yeah, well, we televise him every Friday. If you're interested in seeing him speak, he usually speaks at 5 o'clock China time, which is in Italy, probably around 1:30. So I don't know. That's probably during the middle of your day.
Yeah.
But anyways, any more comments, questions from the panelists? Okay. Well, Lukuya, thanks for pinch hitting during the circumstances when we lost communication with Luhanga. So
welcome.
Yeah. Do you know the topic tomorrow, Lukuya? Because that's one thing I want. Well, I can write to Luhanga. get the topic
Hello,
for the
Dr. Bennett.
Monday. Oh, there you are. You're still there.
Yeah. Tomorrow I'm going to send you the topic and panel members.
Okay. Okay, very good.
Hello, Dr. Bennett.
Yes. We're going to wrap it up now. Okay, Ohanga? Ohanga? And thanks, everybody. We're going to wrap this up. And thanks, everybody, for coming. And we'll see you next week.
Hello, Dr. Bennett.
Yes. Yes. Yes, Ohanga.
Hello, Dr. Bennett.
Yes.
Yeah, I would ask if Professor Andrea could share his contacts for future exchanges for all the suggestions he has given here. I got